Hello, everyone. I'm the host of Going Digital Behavioral Health Tech, and I'm really excited for this conversation today. I have Josh from Hazel. Thank you so much for joining us. We have really important topics to discuss. So before we jump in, can you offer just a brief introduction, please?
Sure. Certainly great to see you. I'm Josh Gollum. I'm the CEO of Hazel Health. And at Hazel, we partner with school districts to bring healthcare access to kids right while they're at school or at home. So we do both medical services, so having doctors and nurse practitioners on hand to help our kids. But then, as we'll talk about today, a big focus on mental health services for kids as well.
Right. And Josh, what is the state of youth mental health, particularly for youth of color?
Yeah, great question. And so it's unfortunately not a great state. It's a great state right now. And I also talk about this as a parent of 3 kids myself. And so if you look at, let's start with the data. So if you start with the data, most of the statistics nationwide say that about 20 to 25% of kids right now should be getting some mental health services. And we talk a lot about COVID being the driver, but actually a lot of this existed well before COVID. COVID has definitely exacerbated it. But of that 20 to 25%, most of the data says that only about 4 to 5% of kids today are actually getting care. So about 1 in 5. But that data actually hides an even bigger issue, which is the health equity lens. And so if you, in this Kaiser study that identified in their study, it was about 4% of kids getting access to care. If you actually broke it down by race, white students were getting, it was about 5.7%. So still a huge gap, need more care. But Black and Hispanic students were at 2.3%. And so we see is a big gap, but the disproportionate impact on students of color is even bigger. And just like as a story, like that's the data, but it's as we've been rolling out Hazel across the country to more and more districts, it's both been really exciting to see how we can help. But it's also, there's been so many stories that have been heartbreaking. And one that comes to mind, a few months ago, we rolled out to a new district. And then as soon as we offered the services in one of our schools, a parent reached out. We've been on a wait list. And this is a middle school girl. She had lost her father during COVID. And she was on a 7-month wait list. So a child who lost her father was on a 7-month wait list. And our case manager, when was talking to the parent, told the parent, we can get your child seen. We can get your child seen on Thursday. And the parent's response when we said that was, Thursday of what month? And so just to put that in perspective of this poor mother who's got her child who so much wants to get her care, that even the idea that to get offered services that the realm that you wouldn't even imagine be possible to accelerate out of them, that's kind of where so many of our parents and families and kids are facing right now, that is incumbent on all of us to try to address.
I'm so glad you offered that example because we hear the dire statistics, but really talking about youth mental health, supply versus demand and access, it's just asinine, frankly. Can you talk a little bit about why schools are getting involved in mental health care? Yeah,
and this is, it's interesting. So schools, for so long, they've been the sort of central point in the community where kids are going not just to learn, but often get access to other services, and whether it's through a school nurse. And in the healthcare world, we talk about social determinants of health. That's been like existing in schools for years. Schools have often been a place for families that might need access to turkey drives for food, for families that need food around Thanksgiving, or kids that are homeless getting connected in. It's a place where everyone comes in the community and there's often services. And so there's always been some investment in mental health, but it's sort of reached a tipping point now where there's so much need. And when it's interesting, there's all these surveys of superintendents of what are your biggest priorities. And if you looked at these surveys a few years ago, what most superintendents would be having at the top of their list would be things like curriculum or new buildings or space. And almost every survey now is around what they call social emotional learning and or mental health. And what's happening is that the fact that there is this crisis, that so many kids don't have access, it's playing out in the classroom. It's playing out in kids' behavior. It's playing out in kids' grades, desire to go to school. And so it's getting in the way of teachers' ability to actually teach, because, and at its most extreme form, fear of kids hurting themselves or hurting other kids. And so I think in some ways, because and then I'm a healthcare person, we in the healthcare system have sort of failed. They're now stepping in to fill the gaps. And so the great part about it is what's happening now at both state and federal level is there's a lot more dollars now coming to school districts to say, look, we will help support you to solve this issue in a completely also equitable way. Because in schools, like schools do not, it does not matter to them whether you have commercial insurance, whether you can pay out of pocket, whether or not you're uninsured or undocumented, they serve all kids. So it's an incredibly powerful nexus point. And what we're finding is that superintendents and school leaders are trying to bring in resources like Hazel to be right at a place where kids are, where there's already trust and with families, and to sort of attack some of that access gap that we're seeing in so many communities today. And I should say, there are already a bunch of fantastic providers that already exist. So if you go to any school district in the country, they'll typically have MOU with local clinics, maybe federally qualified health centers. They're doing great work. They just often don't have enough capacity. And that child that I mentioned that was on a 7-month wait list, it's not that local provider didn't want to see her. They just didn't have the capacity. And so what schools want is to bring in more help, but also to do it in a way that doesn't disrupt their communities and is additive versus subtractive.
You said something so important, this idea of meeting youth right where they already are, particularly for youth who that's where they're getting their main healthcare. So I'm just excited to ask you more about this. But as you talk about partnering with districts, what results are you seeing so far?
Yeah, and I'll focus just on the mental health side right now, but it is like the first set of metrics we've been trying to look at is like what actually happens with access. So when you open up schools, when you make it, and just be clear on the process for mental health today, what we do is we create a referral channel first. So there's an ability for a referral to come from a school counselor, a teacher. There can be a parent referral, or it can be student self-referral. We see them, then we do an intake with them, and typically the parent, depending on what that state's minor consent laws are. And then we do essentially what feels almost like an employee assistance program. So it was a good one, but for kids. So it's like 6 to 10 sessions that we see with the children where they have a clinical need. And then all through this process, we have a case management function. So for kids that we believe will need more than the 6 to 10 sessions, we will then case manage them to a local provider or to the appropriate care setting. There may be a specialty provider they need. But we're finding is the majority of kids, actually that 6 to 10 sessions is exactly what they need to feel well. But on access first. So that's like the first question we ask ourselves is if you made this available within schools, would people actually use it? Would you actually get referrals? And the data has been a resounding yes. And so it's still early, but what we're generally seeing in schools, I mentioned about 4 to 5% of kids are getting services today. In the first year, it's about 3 to 7% of kids will be referred in a district. And so 3 to 7%, and that means these are almost always kids that haven't gotten care before that are now getting access to mental health services that weren't. So it's basically doubling the amount of kids in a community getting access to care. And what's equally exciting is that those percentages that we're seeing that actually that it's equal across all demographic group. And we're actually, I mentioned before that gap between white students and students of color, that both like students across the spectrum are using the service or getting referred in and using the service, but they were actually differentially engaging students of color. And that's been huge for us because we want to make sure the solution that's coming in is helping all kids, but is actually built from the get-go to address the inequities that exist here today.
That's remarkable. It also sounds like the way you explain it, it's really coordinated throughout the entire process.
Yeah. And a couple other things have been interesting. So I'll say there's kind of 2 ways that we see kids coming in the system. So the first way is for parents, the example I gave earlier, already on a waiting list, the parent actually, as soon as they hear about Hazel, reach out to us and we get them quickly seen. And so that's probably about 20% of our kids today. But about 80% are places where the parent and the child weren't actively looking today. And so the symptoms were playing out in some way at school, but the parent, for whatever reason, they may not have even known where to go. They may not have understood mental health as a process. So the first step for us, actually, when a referral comes in for that 80%, is to reach out to the parent in their native language with culturally competent case management to say, hey, this referral came in from the school counselor. Here's what the service is. Would you like to opt in? And And I think we, in the beginning, there's so much talk around stigma, which there is for mental health, but we weren't sure what to expect on that percentage. Because you can imagine, as a parent hearing now from, that your child needs services, if you're not really familiar with mental health means, that can be really scary. What's been exciting is that it's been about 80 to 90%, typically like the high 80s% of parents opting in, which is, and the feedback that they've given to us, our case managers, is that they care a ton about their kids. They want to do, when this offering becomes available, they want to engage and participate it. And I think, again, a lot of it helps that we are doing this on their terms, in the sense of there's things that may be going on at school. Again, we're calling them from a culturally competent case manager who, again, speaks their language and can explain it in a way that is non-threatening, that helps them feel part of the process, and then they want to engage. And that parent we stay with throughout the process, even as we start to now see the child. So for those kids that actually need to go then see a long-term provider, whether that could be psychiatry, it could be some other specialty, or just someone locally, that we've also now built trust with the parent that we're not treating a disease, but we're supporting their kid and their family. And then we can help them then connect into a local provider at a time that makes sense for them.
That resonates with me so much personally. As a youth, I struggled significantly with panic attacks and obsessive compulsive disorder. But my parents, as immigrants, they didn't even have a vocabulary for OCD in either of their languages. And, I talk often about my experience with how many different providers it took to finally find the right one. And I just think about, if this resource was available at the time when I needed it in school, that's just totally life-changing. So it's really important work that you're doing, of course, as you already know, but just to hit that message home.
Yeah, and so it's funny because I so much of the story that I bring to Hazel. So when people ask me what was my own reason for wanting to get involved? So my grandparents, my mom's side, so they immigrated to the U.S. from Mexico, from Zacatecas in the early 40s. Had 13 kids, unfortunately 9 survived. But my grandfather was a painter. And when he was actually the exact age I am right now, he was painting someone's garage, and he has a heart attack. And so the ambulance comes, they rush him to the local hospital. But when he gets to the hospital, because he doesn't have commercial insurance, he has sort of what the equivalent of Medi-Cal was back then. They say they can't see him, and they reroute him to this other local hospital. And was at the county hospital. And so, but while being rerouted, he ends up going to coma and passing away. And so in my family, the story's been for years, the narrative has been that my grandmother, who passed away 3 years ago, raised 9 kids, not speaking the language, in a 2-bedroom apartment, all because of healthcare access, all because and my mom, who I loved, I always wonder if she'll hear me talk on one of these things one of these days. She is both amazing, and she is the worst patient imaginable. And I joined her on a lot of her doctor's appointments, and it is absolutely painful hearing her engage with healthcare practitioners, and she's disrespectful. She doesn't trust them. And as someone who works in healthcare and works with doctors and I'm sometimes horrified, but I have to remind myself, she lived through this trauma, and her lived experience is that the healthcare system wasn't built for people who look like her, who have her needs. And as we think about trying to do things that are built on equity, we have to ground ourselves to this reality that some of the families we've worked with, it's not that they have had bad doctors, but the process that we've set up for them to access care has made it so hard for families that even for, I have good insurance. When I wanted to get access to care for my kids, it was hard. And compounding that, whether or not I'm familiar with how insurance works or the language barriers, that it really pushes a big focus to all of us to say, how do we make the system work for everybody if we really, really want to address health equity?
Thank you so much for sharing that story. And it explains why what I really have found unique about Hazel compared to so many companies that I talk to regularly is you really live and breathe health equity throughout your entire team. Can you talk a little bit about, what is it going to take to move the needle on health equity?
Yeah, well, I think, and it's something I'm glad that it comes across, and it's something we're always trying to do better on. But one of the things, it's just some data points we're really proud of. So more than 50% of our providers, and are on the mental health side, they work typically full-time for Hazel. So they're W-2s, folks who are dedicated to this work. More than 50% of them identify as people of color. More than 40% of our providers speak a second language fluently. And this is actually super important. So if you think about like at a school site, like let's say we're a school in South Florida, there in a given school of like 1,000 kids, there's so much diversity of backgrounds, experiences, language. And you could have the most phenomenal place-based person there that can give great care to kids, but no matter where they come from, they're sort of limited in whatever experiences they can have. And one of the fantastic parts about technology is that you can, there may be a student at 9:30 a.m. that is a native Spanish speaker dealing with anxiety. And at 11 o'clock, it could be an English-speaking student dealing with depression. And at the early afternoon, it's a Haitian Creole-speaking student that is dealing with gender identity issues. And this idea that you can actually start to match for kids the best provider for them is so powerful. So I think one is us as on the healthcare side, trying to design a system with the diversity of the kids we're trying to support in mind, and making sure that all of our providers provide culturally competent care. But some of it is also us really looking at kind of the models and the reimbursement structure, because if we've done this business, it's really, really hard. The amount that gets paid for services between Medicaid and commercial rates there's a huge delta. And that's part of why that there's so many great programs that come out now, but they sort of have to start at the commercial end or cash pay. And I think what we are seeing more and more, which feels great, is health plans, states, Medicaid programs saying, look, we want to make sure that we're not tackling this problem as a country in an equitable way. And so we need to make sure that the reimbursement rate encourages more folks to be able to provide this kind of care. Because I always think that the healthcare system reflects exactly the incentives we build for it. Like you get what you pay for. And we need to make sure that the incentives are aligned, that providers are as motivated to serve a child who may come from Medicaid or even an uninsured as they are for a child that has great insurance or can pay out of pocket.
Yeah, I want to ask you a little bit more about those stakeholders, but you mentioned technology just now. So digital health solutions can be impactful, of course, but how do you bring a program like Hazel to a community without disrupting the local ecosystem?
Yeah, and this is so key because we want strong, vibrant communities, right? Like as much as I love what Hazel, we cannot solve. Our job is to support and supplement the things that are happening in communities and never to replace it. And so it's been really helpful. And when we started some of these services, I'll be honest that like there would be in districts that we would go to, the local community providers would feel very threatened. And they've been serving these communities for 10, 20, 50 years. And to all of a sudden hear about these folks from the outside coming in without knowing more, as it should be, scary. And so a key part of it for us is this case management program. And when we come in and we engage with the local providers, number one is to say, be really transparent that we are not here to become the long-term solution or replace this. Like we are trying to do, if you think about that school of 1,000 kids, like example, if we get about, let's say we get 5% of kids referred in that first year. So it's like 50 kids in that school alone knew that we can help get to services. We're solving that sort of short-term care solution. But, and what the idea is that rather than all 50 of them go to the local providers who are already completely full and can't see them, we're helping to triage, let's say the 15 to 20 that do need care, and working with them to, when a space opens up and a slot opens up, to match them. And so for the local providers, it actually ends up being a big win because they hate having kids on the wait list too, but allows them to match exactly what their capacity is to the right kid and to make sure that it's the highest need kids that they can serve. And so the feedback today has been terrific. And some of the same providers that I think were very asked very good but very tough questions at the beginning have been some of our biggest fans in the community because they see us as a partner and not a competitor.
That makes a lot of sense, Josh. And it's really about making the best of the resources, which are limited today. So thanks for explaining that. And you talked about stakeholders earlier. If we could go back to that, can you talk about what's the role of health plans or for employers and others?
Yeah, I mean, what I would say in the very beginning, I'd say schools, like 2 years ago, and we've been doing this work with schools for 6+ years now, is that I think for for a lot of people, everyone thinks that schools are fantastic, but it was like a scary thing to engage in. And so I would say a few years ago, we had a bunch of supportive health plan partners, but I think it was a bit more hands off. And what we're finding now is that the health plans, and now even to some extent employers, are really leaning in and wanting to figure out how to help, and realizing that so many of their members, the beneficiaries and their members themselves, like this is a great place for them to be able to drive more engagement, and are kind of playing all in with us. And so it's interesting because even with like one of the things that we find for family, most of my work before Hazel was with adults, and there would often be this group of adults. It was really challenging to get to manage their own care, whether it was physical health or mental health. And I'm a pretty terrible patient myself, but I will do anything for my kids. I will go and there's this interesting thing that we've been finding also when we go and serve a child that they may not have been on the radar for the health plan. They're not high cost, but their parent is, and that's someone that plan is trying to engage. And if we can go and deliver this great experience, it doesn't have to be Hazel. Anyone who goes and delivers a great experience to someone's kid, shows that adult that like how great healthcare can be when it's very patient-friendly, culturally competent. We so often get parents saying they want to use Hazel, or they're asking if we can connect them to something. And I think there's this opportunity for us all to use, it's almost like using kids a little bit as a Trojan horse to say, look, we know we can all agree that like, wouldn't it be phenomenal if we can treat kids better? And then to give some of adults like me a taste of that, so that we start to then engage on our own. And I think it's just a big opportunity for all of us to do more.
Wow, I'd never even thought of that. What an amazing opportunity. So as always, Josh, I'm so excited about our conversations, and there's never enough time. I guess if I could ask you one last question, where do we go from here? Can models like this be sustainable?
Yeah, I would say like we are seeing, so what's exciting for us is we typically would sell to school districts. And now what we're finding is that like it's entire states that are coming to us and saying, can we use this as a solution for our state? And so there's this wonderful piece that's coming together between kind of state and federal government, between health plans, between school districts, between providers, so not just Hazel, but like health systems. And I do think that like there is this opportunity for us around kids. And I'll flag, this is something that's not like, we've been talking about health equity, but part of why this is such a galvanizing force is it doesn't matter if you're in the most affluent school right now or the least affluent school, there's huge need. And I don't want to be cynical, say you could have needed that. Like there is some part of me that thinks that like there is this moment right now where every single one of us in the country who has kids or has nephews or nieces is trying to figure out how to solve this problem. And I think there is an opportunity to finally cut through these like walls that exist between bureaucracies to really tackle this in a way that's kid-centric. So I am like ridiculously optimistic. It's ridiculously hard. But even the fact that I can have, someone like you, Salome, that wants to talk to us about Hazel now and be on a stage like this just shows that there's so much opportunity for us to do more and do more for our kids.
A lot of opportunity, and I'm so glad to hear of all the work you've already done, and can't wait for our audience to learn more about your work. Thanks so much, Josh. I invite everyone who's listening to go check out Hazel Health and learn more about the amazing work they're doing. Thanks so much.
Thanks, Salome.